الله الرحمن الرحيم. الصوت واصل؟ طيب إن شاء الله النهاردة نبدأ الفيرست سيشن اوف نيفرو أليكس اللي هو رقم 11 كونفرنس، وإن شاء الله ربنا يسهل ويستمر forever. طبعا بمجهودات كل الموجودين بداية من يعني نقول الأب الروحي للنيفرو أليكس دكتور صلاح ناجي. فبإذن الله كده يكون كونفرنس موفق من ناحية ساينتفك وسوشيال وكل حاجة إن شاء الله تمشي كويس. الفيرست سيشن بتاعتنا الحقيقة من الموست امبورتنت سيشن اللي احنا بنواجهها بصورة قوية جدا النفرولوجي الكارديوفاسكولار كومبليكيشن، والحقيقة من ناحيتين، من ناحية الحاجات الراديو كونتراست ممكن وتعمل كوروناري انجيو الحاجات دي بيبقى فيها problem in renal function، والعكس patient with chronic kidney disease ممكن the most common cause of death or morbidity cardiovascular complication. فالنهارده ان شاء الله هنسمع باذن الله محاضرات قويه في هذا الموضوع. ان شاء الله اللي هتفتتح الجلسات نقول ايه الفلاور بتاع قسم النفرولوجي رايزنج ستار دكتوره ياسمين نجا، وهتدينا محاضره عن heart failure treatment in end stage renal disease patient during treatment and dialysis strategy. اتفضلي يا دكتوره ياسمين.
صباح الخير. It's an honor to be here today. Heart failure in end-stage renal disease patients is the most common cause of cardiovascular disease in patients. Its incidence is about, or its prevalence is about 44% in hemodialysis patients, and it's a very important predictor of prognosis. Mortality or survival in patients with dialysis is usually 80% within 2 years. It is decreased by the presence of heart failure to 60%. So there is doubling of the mortality from 20% to 40% with the presence of heart failure. And the median survival is significantly reduced. Whether the patient has heart failure or does not have heart failure, sudden cardiac death poses the biggest cause of mortality in patients with end-stage renal disease, causing more than 50% of mortality. Despite all progresses, there is still high mortality, and to approach this mortality, we need to approach the patient comprehensively. We need to treat the cause and contributing factors. Should we follow heart failure guidelines? We should tailor our renal replacement therapy, and we should provide comprehensive care to patients to improve this prognosis. Now, treatment of the cause and contributing factors needs a separate lecture. There is a lot of literature, and some of the measures that are accepted in non-dialysis patients, even in CKD patients, like obesity management, is not as effective in hemodialysis management. Actually, obesity is a good prognostic marker in hemodialysis patients. But definitely, if the patient has uncontrolled hypertension, it should be treated. If he has he needs rate control because of rapid EF, it should be treated. So as much as possible, we should treat underlying cause. Should we follow the heart failure guidelines? And this is from the latest 2022 heart failure guidelines. The first line are what they call goal-directed medical therapy. Do they apply in heart failure patients, in end-stage renal disease patients? And then the second line also, do they apply in dialysis patients? Now, the first line treatment, there is lack of RCTs. Even the RCTs that are present, they are mainly done in hypertensive patients, not specifically in heart failure patients. Most data in end-stage patients are observational, small studies, or subgroup analysis from larger trials. And actually, many of these studies have disappointing results, with negative results in some or no benefit in others. Why do most studies fail in hemodialysis patients? Maybe because of the high prevalence of comorbid conditions. Maybe because of the polypharmacy. Patients on dialysis are taking multiple treatments that affect the effective therapy. And there is also poor tolerance among some patients. Some patients develop intradialytic hypotension because of the goal-directed medical therapy. And intradiabetic hypotension causes less ultrafiltration, so the patient will be more congested, and this will increase his likelihood of death. There's also the risk of hyperkalemia in end-stage renal disease patients, which in some studies may affect the outcome. How is the case currently? We have no, of course, data in Egypt, but the latest ESRD data, which was in 2018, shows that 77.5% of heart failure dialysis patients are on beta blockers. I think we also have a high percentage of patients on beta blockers. 44% are on ROS inhibitors or ARNIs, both beta blockers and ROS only 38%. And MRAs, although I'll discuss later that they have a very important prognostic factor, they are only given in 2.4%, and the three together are only given in 1.5%. So why the contradictory results in ROS blockers? Of course, there is concern about hyperkalemia, hypotension, and also loss of residual kidney function, which is important prognostic factors. That's why we usually stop ROS blockers in stage 5 to allow the residual renal function to continue as much as possible. Also, although there are some studies about ROS blockers and they're commonly prescribed in heart failure in dialysis patients, there is few studies specifically in end-stage renal disease patients with heart failure, and actually most ACE inhibitors are dialysable except ramipril and fosinopril, which makes them difficult to use. Some studies found no reduction in cardiovascular events or mortality. However, it is also notable that it's generally safe and commonly prescribed, not as commonly as beta blockers. And there are a single study that showed, or a single meta-analysis that showed that ARBs may reduce new heart failure events and that they may improve survival. But again, there are very few studies specifically in heart failure patients. Now, till recently, there was no data on angiotensin receptor neprilysin inhibitor in patients with heart failure and advanced kidney disease, but there was this, again, retrospective study that examined their role in advanced CKD and included 618 patients on dialysis, 110 were taking ARNI, but actually the result was disappointing again. There was increased risk of heart failure hospitalization with ARNI, and the composite of heart failure hospitalization and all-cause mortality was also higher with ARNI. And the main cause of this negative result was actually the unfavorable outcome in dialysis patients. So in dialysis patients, it may not be wise to give neprilysin inhibitors together with ARB. Now, benefit of beta blockers, again, they are the most commonly prescribed and many of our patients are on them, but they may cause bradyarrhythmia. And actually, the most common cause of sudden arrhythmia in patients with dialysis is bradyarrhythmia. They also may induce intradialytic hypotension. Although many studies have shown improved outcome, they are mainly in heart hypertension, not heart failure, and their effect on sudden cardiac death is controversial, with some showing lower cardiac death and some showing no effect on sudden cardiac death. However, they are generally safe and they are commonly prescribed, so perhaps we have the highest experience with them. And specifically in heart failure patients, there was a retrospective study that found that any beta blocker was associated with better outcome in heart failure patients. But again, this was retrospective, and they found no difference among the different beta blockers with cardiovascular benefit. It is also must be noted that not all of them are equally dialysable. Now, carvedilol and nebivolol, which is gaining effect in heart failure in general, but there are no studies about it in hemodialysis patients, or very few studies about it in hemodialysis patients, is the least dialysable. That's why it's the most commonly prescribed. While bisoprolol, there is some dialysability, metoprolol, there is more dialysability. And this dialysability may affect the patient. So, for example, if patients develop intradialytic hypotension, it may be advisable to give dialysable beta blocker so that it will be dialyzed during the session and will not cause intradialytic hypotension. But in patients who develop intradialytic hypertension, we should prefer the poorly dialysable beta blockers. Mineralocorticoid receptor antagonists, we said they are the least prescribed. However, mainly because they may cause hyperkalemia, may cause gynecomastia. But again, there are multiple studies with actually very positive results in end-stage renal disease patients, and there is some effect on left ventricular mass and left ventricular ejection fraction as a surrogate marker, but they were small studies. However, yeah, I think it's very underutilized. There is some evidence of reduction of cardiovascular morbidity and mortality in several studies, and actually now they are pushing it, especially in patients with resistant hypertension in end-stage renal disease patients. And there are 2 ongoing trials specifically in end-stage renal disease patients, which will include some heart failure patients. And I think they may change our perception of the use of mineralocorticoid receptor antagonist in end-stage renal disease patients. Now, SGLT2 inhibitors theoretically will not work in end-stage renal disease patients, but they have been surprising us with multiple beneficial effects. And there is the DAPA-HD trial, which is still recruiting and may change our perception. But till now, there are no data about it in end-stage renal disease patients. However, we usually continue it until we start dialysis, even in stage 5 patients, and we cannot recommend it until there are more trials about it. Loop diuretics are the last among the first-line treatment, and many hemodialysis and PD patients are non-oliguric, and maybe we should go on or continue their loop diuretic therapy even if they start hemodialysis. It will enhance urine output, allow incremental dialysis so the patient can dialyze once per week instead of 3 times weekly, and it will reduce the need for ultrafiltration volume and reduce the interdialytic weight gain. And there is this recent trial that examined the effect of continuing loop diuretics in end-stage renal disease patients, and actually they used it in patients who were dialyzing 3 times per week, and they found there was reduction in hospitalization, reduction in intradialytic hypotension, reduction in interdialytic weight gain, but there was no effect on mortality. So again, if the patient continues to have urine output and responds to diuretics, maybe we should continue diuretics in heart failure patients. Now, if we review this data, ARNIs should not be prescribed so far. ACE and ARBs, once dialysis is initiated, even if we stop them in stage 5 before dialysis, we may restart them. We should start at minimum dose, watch the residual renal function, watch the serum potassium, and titrate them if there was no adverse effect. Beta blockers, again, they should be individualized. We should monitor the heart rate, aim for the ideal heart rate, monitor heart adverse outcomes, including interdialytic hypotension. Consider dialyzability and maybe use dialyzability in the proper prescription in each patient. MRAs are underutilized and may have a role, but again, we should monitor hyperkalemia. SGLT2 inhibitors, so far, we cannot prescribe them in dialysis patients, and diuretics, we said, as needed. What about the second-line treatment? There's actually, I was surprised that there is a lot of evidence about hydralazine, or not a lot of evidence, but promising evidence about hydralazine and isosorbide dinitrate in end-stage renal disease patients. It's easily titratable, does not cause hyperkalemia, does not cause bradyarrhythmia. However, it has side effects like headache and nausea in some patients and gastrointestinal disturbance. And actually, this study or this retrospective study was only published in June this year, that examined patients, again, it was retrospective, on dialysis with heart failure, on hydralazine isosorbide or without. And actually, the majority of them did not take ACE or ARBs. The majority of them did not take MRAs or beta blockers. But actually, the group that took the hydralazine isosorbide dinitrate had lower all-cause mortality, lower cardiovascular tests, and lower sudden cardiac death, but there was no improvement in heart failure admission. So again, this may give promise that we can use hydralazine isosorbide dinitrate in patients with heart failure. Now, implantable cardiovascular defibrillator and cardiac resynchronization, theoretically they will prevent the sudden cardiac death. Cardiac resynchronization has some improved mortality. However, transvenous insertion may lead to central venous stenosis and AV failure later when we create one, and also it increases mortality in some studies. The implantable cardioverter defibrillator in hemodialysis patient, it was found to increase mortality in some studies. So again, it may not be advisable to use them so far. Tailored renal replacement therapy is an essential part of the treatment. We have to optimize the volume. Optimizing the volume will improve blood pressure, reduce dilated cardiomyopathy, correct left ventricular hypertrophy. That's why we always recommend that echo is done after optimal volume control in patients on dialysis. We'll talk about how to prescribe hemodialysis. If hemodialysis fails, or in cases of refractory, we can move to peritoneal dialysis, which is less hemodynamically, with less hemodynamic effect. Although patients are considered poor candidates for renal transplantation, but actually in some studies they found that patients, the heart failure improved after renal transplantation, and they consider also both renal and heart transplantation, which is not available. But hemodialysis, is it a solution or part of the problem? There is hemodialysis itself is a risk factor for sudden cardiac death, and the highest risk of sudden cardiac death is within the first 12 hours after dialysis, and after also the long dialysis-free interval. And the cause is mainly volume and electrolyte shifts caused by dialysis when it is in the first 12 hours after dialysis, and also the intradialytic hypotension. Intradialytic hypotension may cause myocardial stunning, and myocardial stunning leads to progressive damage to the left ventricle, leading to progression of the heart failure. Also, the vascular access may be part of the problem. If there is high flow in the arteriovenous fistula, it causes high output heart failure with pulmonary hypertension and right ventricular dysfunction. So heart failure dialysis actually contributes to the problem. Excessive ultrafiltration is a very big important part of the problem. It causes the intradialytic hypotension, myocardial stunning. Also, when patients have high volume and we remove it fast, the patient's blood pressure is diminished, so we give him fluids or we stop the ultrafiltration, leading to failure to achieve the dry weight. Suboptimal ultrafiltration will lead to persistent symptoms even if the patient is taking ideal goal-directed medical therapy alone. So it is always advisable to aim for optimal ultrafiltration. How do we do this? We have to accurately assess volume by the clinical parameters, which are the most commonly used, but also with instruments like lung ultrasound, and there are now simplified formulas to assess the hydration in dialysis patient, IVC assessment, body bioimpedance, and also dietary counseling is important. So in patients, we should tell them to reduce salt intake, reduce fluid intake, so that we do not have high interdialytic weight gain. We should preserve residual kidney function, prescribe diuretics in patients who are still have urine output, and we should aim for adequate removal of excess salt, which we can do by better tailoring of the time and the frequency and the modality of dialysis, by sodium profiling, by biofeedback mechanisms. More frequent or longer duration of hemodialysis can prevent intradialytic hypotension, because we reduce the rate of ultrafiltration, but if patients do not comply in it, it will lead to increased cost and it can lead to access failure. Dialysate cooling can be used, but it causes shivering in patients and may be poorly tolerated. Higher dialysate calcium, but it will lead to vascular calcification. We should always stop antihypertensives other than the goal-directed medical therapy. So if the patient is taking alpha-methyl dopa or calcium channel blocker, they have no benefit. We should give antihypertensive drugs that are dialysable after the session, that are not dialysable after the session, and also the dialysable ones. In some patients, we eventually give midodrine before the session, but it leads to higher rates of mortality, probably because patients who need midodrine to maintain the blood pressure have more severe heart failure, and in some cases it may be advisable to switch to peritoneal dialysis. Again, this is only the treatment, the drugs, the treatment of the cause. The dialysis is only part of the patient treatment. We should also give a comprehensive care. Physical activity and rehabilitation have an important role. Nutritional management includes salt restriction, but also maintaining lean tissue and giving patient proper nutrition affects the mortality and affects the heart failure. Treatment of mineral bone disease is also important. Anemia, correction of it will improve myocardial oxygen delivery, but it increases blood viscosity, systemic vascular resistance, and it may increase thrombotic risk. And some studies found that ESAs or erythropoiesis stimulating agents are actually associated with increased cardiovascular morbidity and mortality. However, it is always advisable to correct anemia. So intravenous iron, there is recent results that it improves heart failure alone, and also it gave it with the appropriate erythropoiesis stimulating agents. And despite that there is no consistent benefit, some meta-analysis found that improves left ejection fraction, reduces BNP, improves the functional classification, improves the walk, the 6-minute walk, improves the exercise duration, reduces heart failure hospitalization, but it does not have effect on all-cause mortality. So it's always advisable to correct anemia, but according to the guidelines, we should not exceed 11 grams per deciliter. Now, one of our sponsors is Cedico. They will be giving us at the end of the day, there will be a quiz at the end of the day, and there will be 20 gifts because they are celebrating the 20 years of the presence of the protein in the market, and it's actually the only biosimilar with actual results that found that it is safe, and it is compared to the originator protein. It has lower cost and can be used to attain the optimal control of the anemia. Some do not like that it is in vials, not in preformed syringes, but actually the silicone oil free form, the silicone oil in preformed syringes may lead to immunogenicity and can lead to resistance to a protein later on. So in the end, the care of heart failure patients is a multidisciplinary approach. There should be collaboration between the patient himself, who should be report symptoms, between the nephrologist, between the cardiologist, between the pharmacist to optimally prescribe medication, the nutritionist, and